Welcome to a new edition of What is Global Health podcast. Today we will be talking to Dr. Barun Mathema, an infectious disease epidemiologist and an assistant professor of epidemiology at Columbia University's Mailman School of Public Health. His work primarily focuses on the epidemiologic and biologic basis facilitating disease spread and avenues to better target disease control activities. Much of his work has dealt with transmission dynamics of M. tuberculosis, pathoadaptive evolution, and antibiotic resistance. His research spans not only domestic sites in the United States, but also international sites in nations including China, Moldova, India, and South Africa. The podcast will be divided into two parts. The first focused on tuberculosis and its epidemiological and sociological factors of global treatment, and the second focused on how to address global public health issues, specifically in the case of tuberculosis. This podcast is the first part of the series. You've conducted epidemiological research extensively on M. tuberculosis. What served as the inspiration for this specific focus of research, and what goals do you have currently or have already achieved with this research?
The inspiration behind my focusing on M. tuberculosis, which causes tuberculosis, is really a historic one insofar that tuberculosis as a disease is very much sort of infiltrated in the arts and history and even shaping of societies. And so that was one aspect that was very interesting, sort of as a non-scientist, sort of as a younger person, sort of looking at the disease from a sort of a non-technical perspective. And the other perspective is obviously the burden of sort of human disease that is caused not only historically but also currently. So that sort of served as my sort of my initial inspiration, but and motivation. And to further on that, the more I learned about it, the more I understood that we know very little. That it's a very elusive organism. It's a very elusive disease. It's a very complicated disease, and so that sort of piqued my interest even more. And as far as sort of my own personal goals of studying tuberculosis, is to better understand really how the organism spreads. And so we know it spreads from person to person, and often by coughing or by the airborne route. But what are the other facilities that enable that to happen? And what are the properties of the organism that facilitate this, and what are the properties of the sort of the built environment that facilitate it? And with the ultimate goal of course, of sort of help reduce the burden. So with that in mind, so the few things that I've done is I really employ a whole battery of different techniques and methods to try to study the organism. And some of the contributions is to really understand that not all organisms of tuberculosis are created equal. So you can call them different strains of tuberculosis. You can call them, so some are more virulent, some are more drug resistant, so on and so forth. And really trying to see that the organism, the changes of the organism can actually impact the epidemic trajectory of the disease in human populations.
What is your reaction to the new strains of M. tuberculosis that are constantly developing?
My reaction to that is it is absolutely expected and normal. This is where one believes in evolution. And so tuberculosis, much like all of us, are in constant motion, right? We're always changing. Humans, obviously, we change very slowly. And bacteria change at the rate of bacterial change, and changes typically happen when organisms replicate. So you can imagine how often an elephant replicates or a human being replicates, right? 20, 30 years, you may have X number of offsprings. Bacteria in general will replicate around once every 20 minutes. Tuberculosis this is a slightly different point, but tuberculosis is very unusual in the bacterial world in that it's a slow replicator, doubling every 24 hours. But nevertheless, within 24 hours, within a day, within a week, year, 100 years, you can imagine how much replication may occur. And within each of those replication cycles, there's an opportunity for evolution to happen, i.e. the creation of new strains or the development of new strains. The reaction to that is, it is normal, as I said, but what is important is that some strains, as I said earlier, may be different in their abilities. And when I say in their abilities, it could be in their ability to cause more severe disease, which would be important. And perhaps the most relevant and what has been picked up a lot in the scientific as well as in the lay press is the development of drug resistance. So drug resistance is the case in point example that evolution actually occurs, right? Antibiotics don't cause drug resistance. Antibiotics select for drug resistant strains that already exist randomly through the process of evolution, which is a stochastic process.
How does the evolution of diseases like tuberculosis affect the way you conduct research?
It is a very, very big part of my work. First of all, I'm a big fan of evolutionary studies, and most of my own research really uses an evolutionary lens. So while I'm an epidemiologist, I really, again, sort of steal and borrow from the fields of evolution and ecology to really make sense, again, the idea that strains are not a static phenomenon. They're dynamic. They're always changing. And again, the most tangible change that we can think about is drug resistance. So I track the evolution of drug resistance as it moves through populations. And while that's an academically interesting exercise, it really matters, right? Because the more resistant you become, the harder it is to treat. And there's essentially two ways you can become drug resistant. One is, it's called de novo resistance or acquired drug resistance, where the resistance sort of develops slowly within a patient. That could be for a number of reasons. Maybe the person does not take their antibiotics, they're given bad antibiotics, so on and so forth. Or other comorbidities like HIV or diabetes that may play into making the treatment suboptimal, giving rise to drug resistance, selecting for drug resistance. The other scenario, which is something that I'm very interested in and arguably more problematic, is transmission. So once you become drug resistant, you pass drug resistant bugs, right? Drug resistance is, again, a phenomenon of evolution. It happens, it doesn't happen so frequently, but once it happens, it can spread. And that is what we are seeing certainly in sub-Saharan Africa, in Eastern Europe, the former Soviet sort of states. In the early 90s here in New York City was the epicenter of what they call multi-drug resistant tuberculosis. And these huge outbreaks of 4 or 5 drug resistant organisms. So very, very hard to treat, that were just spreading like wildfire, primarily through the HIV populations and causing very, very high rates of mortality. So yes, very, very much a part of my work is in studying these new variants of tuberculosis and in particular drug resistance.
The HIV population in New York City, as you stated, was disproportionately affected by tuberculosis in a certain time and place. Tuberculosis disproportionately affects certain income and racial groups. What are some of the causes of these differences, and how do you suggest we address these disparities?
Tuberculosis historically has been a disease. So again, let me take a step back. If you, I don't know if you've seen the, I think it was an off-Broadway play called Rent, right? And this was a play that came out somewhere in the 90s, very popular, and it was really about HIV. It was about HIV, AIDS, and it was sort of documenting the social impact and the human cost of AIDS. There's a character there called Mimi, and she is diseased or infected. Now, if you go back a few hundred years ago, there's this famous opera, La Bohème, if you're an opera fan, and it's nearly the same story. but it's about tuberculosis. And there's a character named Mimi who has TB. Okay. So what I'm getting at is it's sort of what's on your mind, it's the societal mind. And tuberculosis is very much in the minds of people back then. This was in Europe where the opera was written. But tuberculosis historically has been very stigmatized. So patients who have TB historically were either undesirables, individuals with poor moral constitution, so on and so forth, right? So there's always, at least in the operas, there's a prostitute, for example, who has tuberculosis, and it's a comment on who this person may be, not on the disease, right? So, to make a long story short, TB is highly stigmatized and it disproportionately infects those who are disadvantaged, so poor. So it is more or less, it can infect anybody really, but it happens to be a disease of the poor. And so disproportionately infects people of much lower income. And therefore you see globally where TB is, there's not much TB in Sweden. At least not anymore. You'll find TB in India, in sub-Saharan Africa, and in pockets of places of London or New York City, so on and so forth. And why that is, so tuberculosis rates are heavily socially structured, right? So you can almost predict where you'd find more cases. And why that may be the case is poverty, in this case, is not sort of a single entity. It comes with a lot of different strings, right? Poverty puts you at risk for malnutrition, for poor health practices, for unsafe practices, access to health care, crowding, which is a very big one because tuberculosis is an airborne disease, so on and so forth. So these groups are disproportionately affected because there's sort of a confluence of factors that make the environment very ripe and just wonderful for the organism to spread and also to break down. So there's one thing we have not talked about which makes tuberculosis extraordinarily difficult is that, and so you should follow me on this one. So Mycobacterium tuberculosis, which is the bacteria that causes tuberculosis, is necessary for the disease, TB, but is not sufficient. Right? Right?
A little unclear.
So what that means is to get TB, which is the disease, you need to have the bacteria. But just because you have the bacteria does not mean you're going to get TB. There's a latency period. So most people in the world, as in 1/3 of the world's population, are infected with TB. But not everybody's going to come down with TB, right? So who comes down with TB is the question, right? So maybe if you have malnutrition, maybe if it's something like HIV, diabetes, extraordinary stress, so on and so forth, right? That will promote the organism that is sitting latently in your body to replicate and to cause pathogenesis that leads to the actual disease. So 2 billion people are infected, but they're not all coming down with TB. We have about roughly 10 million cases a year. 2 billion, 10 million, right? So from that number perspective, we do pretty well. But 10 million is still a big number, leading to about 1.6, 1.7 million deaths.
Because it affects very specific populations, what factors come into play when considering the treatment of M. tuberculosis and infectious diseases as a whole? Do you research methods of treatment?
My personal research does not necessarily directly address this, but a big aspect of it is, not so much how we treat it, but are certain populations more likely, for example, to finish their therapy or to do poorly on therapy, more likely to have drug resistance because of these other factors. Maybe these communities have a different perception of tuberculosis, where they don't think that they should be taking the medication fully or even taking the medication at all. Maybe they should go to a natural healer, in certain parts of the world. Some certain parts of the world, there's suspicion of taking something that is very small, a pill. In the case of tuberculosis, they're not small and they're many, and for a long period of time, that actually doesn't make you feel very well. So, is it making me more ill? So, one can be suspicious, and there's reason to be suspicious. We've managed to make huge swaths of the world's population sort of experimental grounds historically. This is sort of, again, veering completely off about medical ethics and so on and so forth. We've done much better on that. But there is a sense that there's suspicion, there's also knowledge. So, one does have to modulate how you access and how you make treatment accessible, affordable, if not free, and encourage people to take it and keep on the therapy. And it's different where you go. And so that's a very, very important aspect. Arguably, one of the most important aspects of global control is how do you find the cases? How do you tell people who may be sick to go get tested, to get the medications, and to stay on the medications until that's a lot of hurdles. It seems very simple, but if you can imagine, if you are sick with a fever, you go to your clinician, and your clinician says, "Oh yeah, well you have a bacterial infection. Here is an antibiotic. Take it for 5 days, twice a day with food," or something like that. 5 days. 2 or 3 days later, you feel great. And if you're a conscientious person, you're going to say, "Well, my doctor's orders 5 days, so I'll complete my antibiotics." Not everybody does that. Ask your friends how many, or go home and open up your medicine cabinet, see how many antibiotics are, sort of sitting there at the bottom of the pill box. The answer is there shouldn't be any, because you should always finish your course. Tuberculosis is for 6 months, at the minimum. Not for drug-resistant tuberculosis, it could be 18 months, 24 months. And we're not talking one pill, we're talking hundreds of pills that really make you feel awful. So while you may be coughing up and feeling quite miserable with tuberculosis, after about 2, 3, 4 weeks, you're feeling pretty good. Why should you go on taking medication for another 5 months or a year that may make your hearing, you may lose hearing, you may have colorblind, you may have hepatotoxicity in your liver. There's so many side effects to these medications. Why would you take it if you don't know the reason why you should? It's not a trivial factor.